Hello, everyone, and welcome to today's webinar. It's all about revenue, myths, and cardiology best practices. My name is Odd Schooling. I'm the Public Policy Manager here at iHealth and will serve as your moderator for today's presentation. Before we get started, I'll go over a few items so you know how to participate in today's event. Everyone on this call is listening in using your computer speaker system by default. If you'd prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed. You'll have the opportunity to submit questions during today's presentation by typing your questions into the question pane of the control panel. You may send in your questions at any time during the presentation. We'll collect these and, time permitting, address them during the Q&A session at the end of today's webinar. Also, please note that today's slides will be shared in a follow-up email after this presentation in case you want to review again or share with any peers. Before I introduce today's speaker, I'd also like to note that today's webinar is the 8th webinar of iHealth Innovation's MACRA Final Rule series. Please keep an eye out for our final 2 upcoming MACRA webinars focused on primary care and radiology. I'd now like to introduce Justin Barnes. Justin is a corporate, board, and public policy advisor. In addition, he's Chairman Emeritus of the HIMSS EHR Association, co-chairman of the Accountable Care Community of Practice, and partner at iHealth, where he assists organizations with industry strategy and leadership. Justin is also the host of the weekly syndicated radio show, This Just In, on Healthcare Radio and Business Radio X. Justin has formally addressed or testified before Congress, as well as the last 2 presidential administrations on more than 20 occasions. He's appeared in more than 1,200 journals, magazines, and broadcast outlets. With that, let me turn today's presentation over to you, Justin.
Thank you very much, Alex, and thank you to everybody for joining us today. This is going to be about a 30-minute, I call it a high-impact session. MACRA, and as it relates to cardiologists, is fairly vast, but it's actually fairly simple, and so we're going to try to walk through some of those components. And as Alex mentioned, all of this content is going to be available to you. I apologize ahead of time because I am originally from Boston. I do tend to talk fast, but also I like to cover a lot of content. But again, we'll share the recording with you. We'll share all these slides with you, and you can even share with any peers that you want. So feel free to do that as well. Before we dive into the presentation, I'm going to actually touch on the new administration. Obviously, Donald Trump had won the election, and some people have questions. I've interviewed a lot lately on what do we see for changes. And even more recently, Tom Price has been nominated as Secretary of Health and Human Services. And I live in Georgia now. I have for the last 17 years. And Tom's been actually a good friend of mine for about 17 years now. I met him in my early days in Atlanta. So, I actually had a chance to reach out to a few of his team members. And I think that, we're in very good shape. Bottom line is a lot of these strategies were bipartisanly supported and bipartisanly passed through Congress. So I don't see any big changes regarding myths and regarding alternative payment models or anything like that. Obviously, if you're on the health insurance reform side or health insurance side, a lot of changes are going to go along that piece. But a lot of the mechanics here around advancing payment and care delivery models actually started off as Republican strategies back even in the late 90s. So a lot of this has been vetted by both sides. And so the only thing I see Tom maybe modifying come 2018 and 2019 is around looking at simplifying reporting for physicians and care providers. So I think that's he's been a doctor for over 20 years. He's an orthopedic surgeon. Practice here in Atlanta with surgeons orthopedics actually, and specifically he cares about the daily environment for care providers and physicians. So I think that's the only thing we'll see is maybe ease on some of the reporting requirements come 2018 and or 2019, but it's all starting January 1st, 2017, and so you're all in great shape because you're joining us today, and hopefully I'll lay out it's not that complicated, certainly what the media has made it out to be. So starting off with a little bit of a level set. And I always start off here, before we dive right into MIPS and what it means for cardiologists and other specialties, I take a quick step back because 80 to 90% of revenue increases that can come to your practice over the next year or two are going to come from optimizing your revenue cycle and then also looking at your business holistically to see where you can be more efficient and strategies like that and new service delivery that you might be able to offer to your community and new relationships. So, but it really comes from optimizing what you're already doing today and eking out a lot more money, which I promise you can do. We actually guarantee it. So touching on that a little bit, Also, I'm going to touch on that in a subsequent slide, but before we get there, what I'm going to talk about will be around aligning processes, services, and innovations, and specifically conducting business, making conducting business with your organization much simpler, much easier. So let's start off with scheduling. Scheduling tends to be a sore spot for patients, it's a sore spot for hospitals, and a sore spot for practices. And it doesn't need to be. It doesn't need to be a hassle. And you actually want to make it easy to do business and conduct business with your practice or your hospital. There's a lot of tools or even employee alignments, staff alignments that you can do and make that will actually assist you greatly there. And sometimes it's pennies in the dollar of ROI, of new ROI and cost that you can garner. So make it easy to do business with your organization, maybe some online scheduling, or again, looking at different ways to optimize your internal resources or scheduling strategies. Also with appointments, 5 to 15% of future payments are going to be tied to patient satisfaction. They actually already is today for a lot of hospitals, but moving into MIPS and even parts of meaningful use, it's important today and certainly will be important in 2017, 2018, and far beyond. So we want to make sure patients are seen within a timely manner. There's a direct correlation. When patients wait more than 20 minutes, they feel, whether it's true or not, perception is always reality, they feel that their care was not as good. There's a lower value and a lower quality to their care. So, which may not make any sense, but that's a Harris did a study on it and said if they wait more than 20 to 25 minutes, they feel that way. So you want to, and obviously things happen, mistakes happen, no problem. But if your standard patient is waiting an average of 20 minutes or more in the waiting room to be seen, there's something you have to fix within your organization, for sure. And if you start waiting more than 30 to 45 minutes, that's going to really seriously affect you long term, and you will see revenue hits because of that. Either because patients are satisfied, they don't fill out the surveys, they don't return, or they don't want to return for visits or frequent visits or follow-up visits. There's a lot there. So you want to look at that, and then also make sure it's easy to pay bills. Make sure it's easy. Make sure you collect a copay when the patient first presents. Make sure you have the right authorizations or prior authorizations and eligibility. But then also these patient pay applications cost very little and can bring you tens of thousands of dollars of additional ROI and improve your cash flow, and a lot of the times in revenue in general. So there's certain strategies like that. So make it easy to schedule, be seen for appointments, and also make payments. Now moving along to your revenue cycle, because again, this is where 80 to 90% of revenue increases can come from in the next year or two and far beyond. You want to audit provider workflow. You want to optimize your documentation to mitigate issues and reduce risk. Right? So what I mean by that is you want to have comprehensive documentation and notation. Under-documenting is very common, but also that means you're not getting paid for what you did. So we want to make sure that we're capturing assessments, questionnaires, evaluations, services, tests, and screening, because this will all increase your revenue and your cash flow dramatically. And all of this, or a lot of this, will count towards your MIPS or even PQRS or other measures and programs. And you're already doing the work. So make sure you didn't just get paid for what you're doing. I visit practice every single day. I just got back from a swing visiting, I think, seven prospects and customers out on the West Coast, and basically setting up their documentation, making sure their EHR capture this information in a daily normal workflow. They're also setting up their MIPS calculators and MIPS keyboards and dashboards and all that. So there's a lot of opportunity just in your normal workflow to capture all this. I would say that 50 to 60% of what you do today, you can actually already count towards your MIPS and other types of quality reporting initiatives that you have to do or will want to do. So that's one of the areas we start. Random chart audits is something that we do with expert billers, and we look at 10 providers monthly and or bi-monthly. And we want to look at 10 per provider because that'll give us a good understanding of where we have to continue to improve and tweak. And when I say improve, that means we're going to capture certain information or coding at certain times in the visit and integrate it into your EHR. So all this happens without modifying or changing a provider's workflow. And that's where a lot of this ROI will come from. And again, through our expert billers, we'll look for missing charges. We'll look for consultations that happened or no notes or wrong provider noted. We'll look for down coding, up coding, wrong ICD-10 codes, missing modifiers. All of these can be significant revenue increases or will be increases or leakage, as we find today, but they also prevent rejections, denials, and audits. So it's just a great way. It's a great best practice to implement. And again, this is where we guarantee 5, 10, 15% revenue increases and cash flow increases by implementing these types of strategies. Keep the future in mind, as I've already mentioned. You want to optimize your coding as well as your EHR, because it can capture all the codes and the documentation that you need, or a significant portion of what you need for PQRS, for MIPS, alternative payment models, or other quality reporting initiatives. Managing credentialing, something that we've been able to, we drove an extra $9 million of revenue to one of our large health system customers in New York by not only monitoring PAR and non-PAR providers, but we play the game with the payers. We found out that, because we were called in to find out why their revenues were way down, and we found out that the payer, just the game that they were playing, was pulling these physicians off the panels every single month. So we had to go re-credential every single month these providers. But that's what we have to do. We'll do it. We'll chase all that money down. We're tenacious in those types of revenue activities. And a partner like us can certainly assist there. Optimizing collections with eligibility verification, prior authorizations. You want to make sure that you get paid for the visit or the case that you're working on or the procedure. So eligibility verification, prior authorization, very key to that process. Managing fee schedules. We find that 30% of payments do not match the fee schedules. And you've got to go back. We recommend we audit every 6 to 12 months for our customers. And it's very important because, again, a lot of money, we can go back and recoup that money. At the same hospital, we actually went back and recouped some money as well because they weren't paying properly based on the fee schedule. But that's very common. We find that in at least 33% of the customers and our customers that we work with, when we audit their fee schedules, we find those issues. So specifically regarding cardiology, on the denials, and also before I dive into these specific denials, these are just a couple of examples. We actually have dozens and dozens that we bring forth. We specialize in cardiology as one of our coding expertises, and we actually certify for coding around cardiology. But denials is a very important aspect of the business. People say, oh, yeah, we chase it down. When you look, over 40% of denials are never appealed. That is just unacceptable. 40% industry average. And most practices follow in line with that. Between 38 and 42, 43% of denials are not appealed. We appeal 100%. And then once you are tenacious on your appeals, and your appeal strategy, then you also can find out, you get to the root cause. Why are these denials occurring? And let's fix that. Let's go to the root, let's mitigate at the root cause. And now we don't have those denials moving forward, or we can mitigate a portion of them or a large chunk of them. Very, very important. But again, I'm not going to walk through all the denials or how to avoid denials that's on the screen. We'll share these with you. But again, we have dozens and dozens of these examples just for cardiology. So now diving into MIPS and the Quality Payment Program. So the final rule was released October 14th. And bottom line, if you're taking the time to join and hear my voice today, you're going to be just fine, I'm fairly sure. And we actually guarantee, if you partner with iHealth, we will guarantee that you do not receive the 4% cut part of the 2016 program for MIPS, for the Merit-Based Incentive Payment Program. So option one allows providers to report one quality measure or one improvement activity for 4 or 5 ACI measures to avoid a negative payment adjustment, and that's reporting over a 90-day period. So option one is very, very simple. That bar is very low. All you have to do is report one quality measure, one improvement activity, or 4 or 5 ACI measures, which is advancing care information, those measures. And the reason it's 4 or 5 is if you're submitting, if you go for that reporting structure and you report through an EHR that's been certified for 2014, you report 4 measures. If you report on one that's been certified for 2015, which is the MIPS certified version or MIPS version, you report 5 measures. But you need to do one of those. You need to do one of those items over a 9-day period to stave off that 4% cut. So it's very, very simple. Again, one quality measure or one improvement activity or those 4 to 5 ACI measures to avoid the negative payment adjustment. Now, most of our people, we work with everybody on option 1 for sure, but option 2 and 3 is where we want to get everybody to. So option 2, allow providers to submit a mixture of measure and activities data for a minimum of 90 days. You can do 90, you can do 91, you can do 110, 180, 270, 360, whatever, but over less than 365, but somewhere between 90 and 365. And what that means is that you can start a little bit later than January 1st or collecting data. You can get your full 365 days in as long as we have an idea in early January of what you're trying to collect. Because we actually want to get everybody going for option 3 if possible. It's just you're setting yourself up for 3 to 4% increase. But option 2, again, submit a mixture. You can go at your flexibility. If you want to start April 1st or May 1st, then that's terrific. The latest you can start is October 2nd. I don't recommend waiting anywhere near that long because I watched way too many people start meaningful use late and lose out on that their first year, second year money. And it's just not worth it. So option 3 is if you're ready to go in January, and we'll start calculating as of January 1st for the full 365 days, and you'll earn a moderate or positive, moderate to high incentive, and that'll be between 3 and 4% increase. So it's a great option if you can get there and partner quickly. And then option 4 is the advanced APM or alternative payment model version or option, and that's if you're in a Medicare Shared Savings Track 2 or 3 or CPCI or even the oncology track. There's options there, the oncology program. So those are the 4 options. Very, very simple. Option 1, if you're taking the time to hear me today, you should very simply, and we guarantee that you can certainly achieve option 1 and succeed with option 1, but we want to put you towards option 2 or 3, or maybe even 4. Here's the incentive dollars that we're talking about. For year 1, it's a full 4% increase, or up to a 4% increase, I should say. But if you choose to ignore the program 100%, you can get up to you will get a 4% cut. So I don't recommend you, and these are all cumulative numbers. So please don't just ignore the program, because then you go to additional 5% cut in year 2, or up to an additional 5% increase in year 2. You'll get a 7% cut, or up to a 7% increase for year 3. And then year 4 is up to 9%, or you will get a 9% cut. That's 25% that you just don't want to leave on the table if you don't need to. Either direction. You certainly don't want the cuts, and you certainly want the money. Then the other ones are the advanced APMs. I don't know if we have any of those on the line right now, so I'm not going to cover that ground. But now I'm diving into the categories. So there are 3 categories for 2017, and there are 4 categories for starting in 2018. I was counting for the 2017. We're going to focus on the first 3: quality, advancing care information, and improvement activities. So quality will replace PQRS, and that accounts for 60% of your total performance score in year 1. The second category is advancing care information. That will replace meaningful use, and that accounts for 25% of your total score. And then improvement activities accounts for 15%, and that's a new category. Now I'm going to walk into all of these, and again, in 2018, we'll start the resource use cost, but now we replace the value-based modifier, but we're not going to talk about that today because it'll start in 2018. So now specifically diving into these 3 categories: quality. There are 60% of your measure and 20 cardiology measures to choose from. So again, you only need to do 1 as part of if you want to stave off just that 4% cut, 1 quality measure. You have 20 to go through, and you can report up to 6. If you report all 6, then you're well on your way towards getting your 2, 3, or 4% increase in payment. But you only need to do 1, again, to stave off that 4% cut, but you have 20 to choose from. The reason we like to point out the number of specialty measures there, you have a lot of flexibility. So this is really meant for your workflow and your specialty, and specifically cardiology. So you have 20. You can go through, and we actually, as best practice advisors, we'll go in there and tell you which ones best fit your workflow. So that's category 1, quality. Category 2 is advancing care information. I already gone through this a little bit. Option 1 is if you have a 2015 meaningful or certified EHR. That's the MIPS certified one. There are 5 required. You have 15 measures to choose from. You have to report only on 5. Option 2 is if you have a 2014 certified EHR, and you have 11 measures to choose from, and you have to report on 4 of them. So that's the advancing or ACI category. And now improvement activities. That's a new category. There's up to 4 improvement activities. You have 93 to choose from. And we're going to go through, I'm going to show you all these different quality measures and activities here in a moment, so you can kind of see it. For cardiology and for all these specialties that we go through, we like to kind of package it all up so you can kind of see all the information. And again, we'll share this recording with you, and we'll share this slide deck with you as well, so you can see it all. But we put everything in a nice little package here for you. So again, under improvement activities, it's 15% of your weighted score, and you can go up to 4. Now, if you have less than 15 participants in your practice, then it actually reduces down to 2 activities. But you also get bonus activities if you report up to 2, 3, or 4. So it's great. You have 93 to choose from. So again, a lot of flexibility there. So before I dive into all the cardiology specific measures, A couple of takeaways. This is all pick your pace. You can start when you want. Just don't start too late in 2017. And hopefully in January, February, March is a great time. Or even December. Like I said, I'm on site weekly now with practices and health systems, setting them up and setting their practices up. Highly flexible, so you can choose which measures and objectives best fit your practice, your specialty, and your workflow. So as I mentioned, there's 20 to choose from just for cardiology in quality. And then 93 measures on improvement activities, and 11 to 15, depending upon the ACI measures, the advancing care information. So again, lots of flexibility to integrate into your workflow and pick what's right for you. It's also, unlike meaningful use, it's not all or nothing. You can get partial credits, bonuses available, so you can avoid penalties and also increase payments. I also developed about 5 weeks ago, published a 4-point plan for MACRA and MIPS success, and something that you guys can go check out. You can, when the slide deck comes out to you, you can click on the link below, or you can go out to Beckler's Hospital Review and find it. But I kind of go through 4 major tenets: financial success, clinical success, technical success, and how to have staff success and staff alignment, and bring everybody along with you. This is change management in a lot of ways. It's not just about trying to get incentive dollars. It's really about a new strategy of managing healthcare internally as well as externally with your patients. So now diving in specifically into cardiology. So here's some numbers. We always like to show numbers, and then we'll show you the measures and activities next. But for an average 5-doctor cardiology practice, you can get up to $44,000 in your first year, or a $44,000 cut if you ignored the program, up to another $54,000 year 2, another $76,000 year 3, and another $98,000 year 4. So that's for a standard 5-doc cardiology practice. Now, cumulatively, what does it look like? If you ignore the program, that could be a $273,000 cut over 4 years, or work up towards a $173,000 increase over 4 years. So it's a great, you know, care. Not only, and this is what CMS is doing based on your Medicare population. However, this is also what all providers and payers are moving in this direction. Strategically, if you're participating successfully in MIPS and other quality reporting programs, you're going to be kept on panels. You'll keep your referral sources strong, and a lot of the other quality rating programs will pick this all up. So you do want to pay attention and participate. Even if your Medicare population is low, this is still something to pay attention to. I promise you that. Strategically, it'll position you very, very well. As I mentioned, there's 20 cardiology specialty measures to choose from. You only need to do one to stave off that 4% cut, but if you want your full credit for the quality category, you report up to 6 of these. You have 20 to choose from. You only need to report 6, and here they all are. Here's all 20 measures for cardiology. Again, just for the sake of time, I won't let it, chance to go through all of these, but we'll be sharing all this content out with you. It'll all be packaged up nice and neat, and you can go through it as your leisure. I'm sure a lot of these you already do. When we audit people's workflow, our providers' workflows, we find out that they're doing 40, 50, 60% of the work already today. And all it is making sure that your EHR is set up to capture it and your coding is set up to capture it, and then that we can report on it. But a lot of this work is already being done with your patients every single day. You might as well make some more money doing it. So again, this is all 20 measures under the quality category. But again, I don't have time to slow down. It's going to, I just want to show you what it's all packaged up into one presentation, and we'll ship it off to you here shortly. These are the outcomes measures, because you do have to do one outcomes measure as part of your quality reporting. And these are all the ones to choose from. And if there's nothing that's even relevant to you, there is for cardiology. But even if there's not, you can just pick your regular standard quality measures and just do all 6 quality measures. And these are all the non-specialty specific quality outcome measures continue to. Again, we'll be sharing this all with you so you can see. Now, on the improvement activities, there's 93 total to choose from. 4 medium-weighted and 2 high-weighted are necessary for full max credit. However, if you operate in groups less than 15, then 15 participants, then you actually can have that cut in half. So there's a lot of flexibility on picking these. So again, 93 to choose from. You need either 2 or 4, depending upon the weight, depending upon the size of your practice. And the red H next to these show the high-weighted ones. And again, we'll be sharing all this out with you, but all 93 are on these 2 slides. see them. Again, the red H stands for the high-weighted ones. So if you want max credit or even bonus measures, you can do 2 high-weighted ones or 3 high-weighted, 1 medium, and you get bonus credits. It's a great program. Again, partners like us, we love to assist you in this. So those are all 93. Now for advancing the ACI measures, advancing care information measures, here's a sample. I don't believe we have all because there's just 2 different versions. There's 11 or 15 depending upon your EHR certification level, but those are very easy to find. Here's a mixture right here of those. So now, what will it take to succeed financially? I've gone through a lot of this, but just to recap, we want to make sure that you're getting paid for all the hard work that you're doing, and that you're not relinquishing any money. So really do focus on operational efficiency on the clinical as well as the financial side. Pay close attention to the nuts and bolts of your practice. You want to optimize and make sure that you have comprehensive coding. You want to make sure your claims are clean going out. You're chasing down denials. You're chasing down 100% of denials and appealing 100%. And you're going after root cause to mitigate future denials, checking eligibility and authorizations. You're looking at close attention to payer contracts and variance rates to make sure that you're getting paid to what your contracted rate is, and having KPIs and key performance indicators set up. You want to have these on the dashboard for financial and dashboard for clinical. We want to see how our revenue is doing and also how we're doing, whether it's going for meaningful use, for PQRS, and certainly for MIPS and any other payment models that you want to engage in. And make sure that all this becomes integrated. The population healthcare coordination, these are the heart of all these new payment models rolling out. And we're going to need to integrate data from clinical and financial sources. So hopefully, you have a good partner that can help you pull all this together and customize your EHR to your workflow and make sure you have the dashboard so everybody can see the success that's happening. You're implementing best practices, and we bring a lot of those best practices to you, I mentioned even on the coding side. But then also we review a monthly or quarterly scorecard to see how you're doing on your KPIs, clinical and financial. And you're coordinating care across the entire care continuum because that's going to optimize your outcomes and optimize your financial opportunity. It'll increase revenue, I promise you. And then opportunities for patient engagement, education, empowerment. We've got to make sure that we are giving tools to patients to help them manage their own care, for them to stay educated on their care, for them to engage their care. They may visit other providers and get prescribed other drugs by other specialties, and you want access to understanding that, knowing that. And patients can enter that into their personal health record or at least into their portal, and then you can review it and you can approve it, before it goes into their record. But at least you have access to that information. And all the work that they do is free because they're doing it on their time, but you're getting the benefits. So please use patients where you need to. I personally believe, and if you've ever met me or heard me speak before, I personally believe that all care providers that intentionally and deliberately engage with new payment and care delivery models and create the right partnerships will have more opportunity in the future than they have today. I live and breathe this every single day, and I love it. I sit with hospitals, I sit with practices, and I look to see how can we increase revenue. And we guarantee 5, 10, 15% based on revenue cycle, based on quality reporting, based on programs. It's not difficult. It's just getting the right advisors and the right team aligned with you. So, Alex, I'd love to take some questions here if you want to get them queued up. In closing, for everybody else, there's some great resources. CMS has a great website, qpp.cms.gov. If you want to look for all the different measures, we're going to send everything to you. So if you ever want to go see their website, that's great. Again, iHealthInnovations.com. We keep a lot of this posted out on our website. A lot of best practices, webinars, future webinars, recordings of all of our different webinars. And also, CMS has a great website, innovation.cms.gov, that tells you what's happening in your backyard and happening all over the country for evolving payment and care delivery models, public and private, which is very good to know. And then also in closing, Medicare Physicians Compare, medicare.gov/physicians compare. They highlight every provider that participates in Medicare, so where they participate in meaningful use, PQRS, and they're going to highlight in detail providers that participate in MIPS and the Quality Payment Program. So it's very important to see what Medicare is saying about you, because patients are starting to see it, and they're pushing this a lot more. And so this kind of enters in the consumerism of healthcare. So do understand what's out there being published about your practice. Alex, I can turn it over to you for any questions I may have.
Thanks, Justin. We are at the top of our time, so out of respect for everyone's time, we'll only address a couple of questions. Our first question is, can we get bonus points on our quality if we report on more than one high priority measure?
Yes, great question. And yes, you can receive additional bonus points if you report outcome or high priority measures beyond what is required. And we recommend it, and it's the best practices for us that we could implement for you to be able to capture that. Because again, we do want to go for bonus. Some of the stuff is low-hanging fruit, and these bonus options are great to go for. So I highly recommend it. Great question.
Great, thanks. And our final question, do we report improvement activities through our APM?
If you are an APM but participating in MIPS, yes, your improvement activities would be reported through your APM model. So yeah, that's a good question, and it can get a little bit tricky. But yeah, if you are an APM but participating in MIPS, yes, your improvement activities would be reported through your APM model. Great question.
Great. Well, thank you, Justin, and a special thank you to everyone for taking the time to attend today's webinar. It's all about revenue, MIPS, and cardiology best practices. Once you leave today's webinar, you'll receive a survey on the presentation, and we'd appreciate if you'd complete that and provide your feedback. As a reminder, today's slides will be shared in the follow-up email within 24 to 48 hours, and we'll also include a link to view a recording of the webinar in case you want to review again or share with any peers. On behalf of iHealth Innovations and our presenters, thank you for joining us today, and have a great rest of your day.
Thanks, everyone.